And we are going to go ahead and have our task groups join us here on stage. We're going to take about the next 45 minutes to examine a lot of the work that's coming out of the roundtable. Specifically, most of that momentum is coming from our task groups. So if I can have the task group chairs, Evidence-Based Promising Practices, Dr. Beth Calhoun, Tricia Strusowski, I almost said it wrong, but I totally did it right? Policy, Dr. Freund, Katie Bathje, and Elizabeth Rohan, and then Training and Certification, Dr. Linda B, and Dr. Patti Valverde to please join us. And while these folks are coming to the stage, can we go ahead and also have the steering committee members please stand up? And we'd like to acknowledge all of your work too. So steering committee members, if you could please stand, and a quick round of applause for everyone who's walking and standing. Great, thank you so much. So we'll go ahead and have everyone join us today. So we're gonna, so actually lucky for all of you, I did see the Oprah exhibit within the African American Museum, so I'm really super stoked to try out my facilitation skills, much like Oprah. Pretty much sure that I really learned a lot in that whole opportunity. I'm really actually not gonna be doing a whole lot of that per se, but these folks are gonna spend about the next 10 to 12 minutes with each group to share a lot of the work and the momentum that we have developed here over the last year, where we're going, and then also what we see as some pivotal next steps moving ahead. And I do think this is really going to help inform our thinking through the day. We'd really like to think about cross-pollination between the groups. And I think to Rich's point around the 5 points, really thinking about where we're at, where we're going, and where we need to be. So with that, I'm going to go ahead and turn it over to who wants to go first? Who's there?
Beth and Tricia.
Yeah.
We went in order just like you put it on.
All right, perfect.
We went in
Well,
order
there we
just like you
go.
put it on the slide. So thank you very much. It's actually an honor to be working with these ladies. We actually got together back in Denver, and it was really quite a bonding experience to get to know them. So thank you. It was really very, very much appreciate all the support that you've been providing for us. So the evidence-based promising practices. So, you know, Beth and I have really bonded a lot over this group because sometimes we felt like we were herding cats. We have a very active group and a lot of discussion, and we thank you so very much because we did a whole lot of work over the last year. We did an extensive literature search in regards to patient navigation. We looked at hundreds and hundreds of articles. We then actually had a first set of navigation metrics in regards to patient experience, clinical outcome, with an emphasis on return on investment. We then did another survey to start to narrow down the navigation metrics and what was the most important in regards to all phases of care, from screening through survivorship and end of life. But then we also wanted to look at what's going on in healthcare right now in regards to value-based cancer care. We looked at the national standards, COC and NAPBC, but then we also looked at the indicators. We looked at the oncology care model indicators, we looked at MIPS, we looked at APMs, we looked at COPE, and we did a crosswalk. We looked at every single navigation metric that we chose, and we actually wanted to know which value-based indicator or national standard supported that metric. So we're very proud to say, after 10 long months, we have 23 metrics that we actually support what's going on in our healthcare landscape, to also show patient experience, clinical outcome, and return on investment, because we want to set our programs up to succeed, and we really need to have that for sustainability of navigation. You know, we also need to be able to articulate navigation. It is part of the navigator's role, but then we also know that we're going to have to help them with that, and that was part of our discussion yesterday in regards to a toolkit and next steps. What we also wanted to do, and we specifically told our group, say, please listen very intently to all of these discussions because we need to cross-pollinate between our committee work. It's so very important. And I definitely have to echo what Tracy said. Our timing is now. I mean, we've all been doing this for a really, really long time. But when you look around the room, who is in this room, who is on this panel, this is our time to do it, ladies and gentlemen. You know, we have all the national organizations. We have all the associations. We have Biden Cancer Initiative. We have American Cancer Society. We have AON+, we have ONS. You know, we have all of our, you know, organizations and national organizations. And guess what? We can't be duplicating. We have to work together and we have to collaborate. Our stars are aligned, but this is the time to do it. So I actually told our committee, we told our committee yesterday, you know what, we are the leaders in this room, and it's our obligation to our navigators, to our patients, to make this happen. So where we are in different settings or in different meetings, and some of this information come up that we're going to share with you, please say, you know what, that work's already being done, and let's go collaborate with that group. It's going to be essential for us to stand up and say that as a team. So I want to actually share with what we're up to with the study, so I want to turn this over to Beth at this time.
So one of the other things that our group did, so we accomplished, here's a set of sort of minimal metrics that will help you create a business case for sustaining navigation within your health systems or in your community health organizations. But our group is also embarking on a national survey. So what we really want to also find out is how easy or difficult are these metrics to collect? And what are those barriers that you have that you encounter in collecting the data? Because I think one of the outputs of the roundtable can be support in the, what are those challenges with your EMRs? Do we need to work with Cerner and Epic and others to make, make a tangible solution to, in having navigation become embedded in our health system? So our evidence-based practices group is looking to not only share what we think are the evidence-based metrics, but also come up with solutions that we think will be helpful for collecting these data to provide the support that will ultimately help navigation become, as Rich said, consistent and across all places, including rural America. So I think, do we have time for questions? Is that what we were going to do by each group, or what are we doing?
So we actually were going to hold those until
The end.
I think after we hear everyone's
Okay.
work. Want to make sure Linda's not running away as well. So
All right.
All right. So great. So I think
Okay.
we'll go ahead and have the policy group and give the. And you guys are all set.
Yeah.
That was you. All right. Fantastic.
Great. Well, I'll speak for a few minutes on behalf of the Policy Task Group, and I just want to thank both Katie and Elizabeth for all of their hard work and the hard work of our committee. It was really, I will say that one of the real advantages of these annual roundtables is there's a real advantage of these face-to-face meetings, and the fact that we had the meeting a year ago with our task group and everybody got to know each other really, I think, facilitates doing a lot of work by conference call. We all spend a lot of time on conference calls. Our offices should be cleaner given the amount of time we spend on conference calls. But nevertheless, I think we did a lot of really great work, and I agree with the fact that we brought together so many perspectives to really move the work forward, I think was really important. So one of our major accomplishments this year, in collaboration with the Center of Health Law and Policy Innovation at Harvard Law School, the Policy Task Group has developed an issue brief that is really looking at the issue of sustainability. So I think if there's one issue that the Policy Task Group has really been tackling, and kind of our focus is the sustainability, and how do we develop sustainable models within our health, especially as our healthcare models, our payment models, and our health delivery models are shifting. And so we've developed a brief. It will be out on the website very soon. We've entitled it Patient Navigation and Cancer Care, Review of Payment Models for a Sustainable Future. And the issue brief really provides a framework for addressing the funding issues in patient navigation. It gives an overview of existing payment models and sort of proposed future models, and then provides some recommendations. So in our task group meeting yesterday, we really focused on two issues. One is how do we disseminate this information? And we had a lot of discussion about both the groups that we all represent and how we in the room can get this information out to our membership, but then also thinking about who are the people that are not in this room. Especially we had a lot of discussion about administrators, hospital administrators, cancer center executives, and groups that may not be as well represented and how that information might be useful to those groups. We also had discussions about putting it together as a policy brief that might go to policymakers. And then our next project is going to be working on developing a business case and really developing some tools about the business case at the local cancer center, the local hospital level, and really defining the return on investment for an institution for patient navigation. So those are kind of the two pieces that we're working on. We're delighted to have some discussion about how we're going to move forward on those.
Thanks, Karen, for the heavy lifting in that reporting. And I'll just add that the power of the roundtable for us as a policy group last year was when we tried to decide what policy to address. There's so many things we could talk about, big P, little p, so many things. But as we brainstormed, talking about sustainability bubbled to the surface, and the power of the roundtable was we had a room full of people who were experts and had the Harvard Law folks stand up and say, you know what, I think we can contribute to this. We have someone who's looking to do a paper, and this might be the perfect topic. So we were like, yes. Hello. Is Sarah here? I thought I saw Sarah Downer. Thank you so much, from Harvard Law. Thank you. Sarah and Katie and Kemi and her team pulled together the resources and the manpower behind what we were doing, woman power, and it was a wonderful document. And what I like about the document is it's extremely practical. It is not an academic paper, although I love academic papers, but it is something that will be very useful. I'm from rural Kentucky. For those rural hospitals, as Rich alluded to, that are trying to kind of do this in some senses, some ways, on their own, can look to this as a QI document to say, what is feasible for our small hospital? What can we do to pay for this? So we hope that you'll find it helpful as well.
I don't have a lot more to add because my colleagues, Karen and Katie, have done a great job. But I wanted to say that, coming together in person is so valuable, and it was great. Our meeting yesterday, we were so efficient. We ended early. I was in shock, and we had a really great time. And I felt like, last year it took a while to really to get there, to figure out like what we were going to think about. But this year, when we talked about, well, here's what, some ideas, what do we think? And we were kind of all together because we've been working for this past year together, and I think we were all on the same page, and that was really remarkable. So, all right, thank you. I'm passing it back this way. But thank you to the work group, task group.
One more thing I will say, as far as the big P involved with this issue brief, is Elizabeth from ACS CAN was in our group yesterday and reminded us from where? Elizabeth? Cancer Support Community. Thank you, Elizabeth Franklin. Thank you for being in our group. And she said, this would be great for legislators to see. Is there a way that we could have a small group of people that go meet with people that are friendly with the bill that's in front of our legislators right now to kind of explain this and inform their staff? So there's a lot of ways that we can use this. If you are from, like me, a state coalition, and you need support to know how to do that for your legislators, please let us know, and we'll get you in touch with people like Elizabeth or the ACS CAN folks in your state, and we'll try to make that happen.
Wado, I'm Linda Burhansstipanov, or Linda B. And being techno-Indian, we of course have slides that we're going to be putting up. And unlike their group, our group will always go a long time because I'm Indian. We have to do things when things are right. Hey. I would like our task group members to stand up, please. It's Sandra, Paula, Beth, Carrie, Andy, Sharon, Allison, Sheila, Steve, Angie, Jean, Lily, Megan, Carla, and Katie. Please stand. All right. This is one hard-working group. We like to get things done, and the group was very, very generous, and they set aside a lot of their personal favorites and kind of the collective ego of our program's best and whatever. All that was put aside immediately so that we could move forward in a good way. There you go. Thank you. Yeah, you can see it down there, too. Okay, good. So we wanted to first start off with what our accomplishments were in 2018. And we had 4 questions that the group raised last year in November 7th. And one of the first one is, can criteria for a core set of competencies be established that specifically address the role of patient navigators regardless of whether they are clinically licensed or not? Because we want to be inclusive in everything that we are doing. The second question that we raised is, how available are patient navigation training programs in the United States right now? What components of patient navigation are included in the different trainings, and what programs base the training content on competencies? And what we learned from asking these questions is that collectively we reviewed a lot of the key programs that exist nationwide, and we came to an agreement on competencies. We did not take anybody's verbatim language for anything. We said, we have to agree to kind of give up some of our personal favorites and find a way that we can standardize concepts and ideas to move forward in a good way. And that is what the group definitely did on this. We reviewed approximately 60 programs that were advertised on the internet as providing patient navigation programs. And then the task group individually identified different programs and followed up with email and with telephone calls to try to clarify what was missing, because none of the information on the websites was complete, not for a single program. And that was fine. Then it also to emphasize that this was nationwide, that we reviewed these different programs. Based upon what we learned, we drafted a commentary. Now, it just started first summarizing what the heck we had been doing. And it started with 14,000 words as of last April. We decided we wanted to submit it as a commentary to, ideally to cancer, and it had to be cut to 5,000 words. So we did get that done. We're having a little final editing done. Sharon's going to jump in and help us this weekend, and Patty's revising a final table, and it will be presented or submitted to cancer on Monday. We identified, within the document, we identified 10 programs to illustrate how very different patient navigation is from one setting to the next and from one role to the next. And that was rather important, because what we want to make certain is that one size does not fit all people in all programs, and that programs have to have the flexibility to have standards that can be adapted to what is needed in their local community, whether they're in a rural area or a booming city, whatever. But we also need to have some type of standardization. We need to have a minimum set of core values, in a sense, that can help us move forward in a good way. And I'm going to turn it over to Patty. Oh, you got your own. Wow.
Okay, I just wanted to mention, of the 10 programs, to give you a flavor of what we did find. So we highlight a program that's at a community college, a program that is at a cancer center, a program that is focused on social workers or peer navigators, another one that is nurse navigators. So the range is really phenomenal across the country about what we found. But we do, we do call for standardization. And yesterday in our task group, we discussed what we want to tackle for this coming year. And overwhelmingly, the group wants to look at that further standardization among the tasks and the role of the navigator. However, we always have to acknowledge that there are a variety of settings that you'll find navigators. There are navigators across the continuum, and so we, how do you develop standardization knowing that there are those, differences in, licensure versus non-licensure, tasks and roles, settings, and so that is what we're going to tackle. Another thing that we hear about constantly from the community is the need for, that basic job description. So based on the tasks, the roles of the navigator within the different settings, the competencies that are common or core, what kinds of job descriptions would be typical. And so again, the task force is going to work on that. So again, acknowledging that we have both the lay navigator, nurse, social worker, looking at the role of the financial navigator and trying to integrate that into the, the overall navigation group. Yeah. Another thing that came up is making it very clear what a navigator is not. So again, we want to develop the tools that can be used out in the community by the employers and in different settings to help them clarify when they're setting up a navigation program. So what we hope to do is begin with just discussion and clarification and delineation of those roles, and then that will feed into the job description. And we have a large group, so we may break up into smaller groups. So in our general discussion, we talked about how other types of issues that are relevant for the other task forces. Many people highlighted the fact that we do have to integrate the financial navigator into our review of training, review of roles, and those job descriptions, and so how we go about doing that. We also discussed this in the paper that the idea of some type of governing body or entity that can monitor the progress for standardization of the competencies, and that keeping it a neutral body. So the need for that. And it could be that it's the Roundtable, or maybe it's some other entity. Also that another comment that came up was how to support the navigator within the healthcare system and standardizing that. It goes back to reimbursement, and so that feeds into the policy and the evidence-based work group. Again, we're all trying to move towards not having to rely on grants to continue this effort. And there was a request to look at how do we standardize the resources. So there's certainly national resources that can be used across the country, and then we know there are local resources, but how can we make sure that navigators across the country are aware of and can fully utilize those national resources? So we discussed a little bit about certification options. We mentioned or highlighted what AONN is currently undertaking, but there are other options as well. And in our paper, we wanted to make sure that the task force was in agreement about this call for some kind of standardization of training programs, some type of governing body, and there was consensus around that. We also discussed dissemination efforts of the work of the training task force and came up with a very long list of organizations and some discussion around what is it that we're disseminating. So we have the paper, but then what is the next step? Across all of the workforce or the task forces, we will be developing a 2-pager, and so that is something that can be used, but certainly our list of training programs that we identified, and then as we work on role delineation and job descriptions, that will be could potentially be widely disseminated. We were asked to support the metric survey that is being developed, and so we had lots of different suggestions around content or questions that could be included, and so we will be working on that over the next week. Right now, I think we have 20 questions for you, and somehow we'll get down to 2. And so we had a very productive meeting.
I think we also reiterated the fact that it has been an extremely collaborative process. We started off very well last year, and the task group has been highly involved, and we have now a manuscript that will be submitted. So it with a call to action. So it's been a wonderful, wonderful experience. Oh, did you want to say something? Yes. Mm-hmm.
Okay, great. So we have plenty of time for questions, for thoughts from the audience. I think we want to spend a good bit of time, really even amongst the group here as well as everyone in the crowd, to really think a little bit about the cross-pollination, where this work is going, from what we heard from Rich this morning, and then with a lot of the leadership in the room, thinking about what we can do to propel. And I just want to add, I think amongst all of these groups here, part of the biggest theme yesterday was really about the dissemination, and I think everyone touched upon this, but we're also thinking now that we have this foundation, that it really builds upon the work and complements other initiatives that are happening. How do we make sure that this doesn't just sit on a shelf? I think we had some great examples of how this can work in different settings with different groups to move things ahead. We are really thinking about what are the sectors that we all interface with. How do we have tangible products that we can bring to show the relevance of the work that's come from this committee to help really move to make sure you get a navigator, you get a navigator, you get a navigator. That's my Oprah contribution, that's all I got. So just to make sure that we really have folks that are really trained, who are doing the good work, all the points that were mentioned this morning. So I do want to say that we are putting a lot of good thought into what are those products, what does it look like. It is great to contribute to the literature and have white papers, but we also need to make sure that this really works for folks on the ground who are working in the implementation and making the case. So let me go ahead and open it up to the group and see if there's any burning thoughts or questions, and then I have a few of my own. So just want to be respectful. Anyone else? Anybody? Specific thoughts? Yes. Yes. I thought you were going to go off the site again, Linda. I was like, no, no.
I have a question.
Raise your microphone.
So interesting about the financial navigators, right? I think that one of the things I did with my navigators, because I had had a role in training for the ACA in Illinois, I actually have had them be certified through the federal programs. I mean, do we, I don't know, did we touch on that in the paper or no?
It came up yesterday in the discussion of the group at least 3 times that people were talking about the demand and the need for people who really can address financial issues while they're navigating the patient. And it certainly is something that Harold's had in his program almost from the beginning, right? Yeah.
I mean, one of the things we were able to do is get people enrolled on the marketplace, and then they were able to start treatment, right? So people that were uninsured, you know, the Medicaid, you can, if they qualify, you can get them on, and it's retroactive. But an important thing, I think, for us to be thinking about is how do we really embrace that, because a lot of places don't have a lot of help around the financial toxicity of cancer.
So in the issue brief, we specifically left out navigators whose sole role was insurance enrollment, because we really see navigation as providing services around the clinical care that the patients need. So we sort of called that out as being kind of a little bit outside of what we were calling a patient navigator, knowing that part of navigation, is the financial piece.
I'm Jean Sellers from UNC in Chapel Hill, and I just wanted to say that if we as a group do not address the financial toxicity of cancer care, we're doing a huge disservice to our patients. I can't speak to other states. I can speak to North Carolina. We have rural cancer centers who are eliminating the role of the social worker. So we are trying to work really hard with the navigators, and we're finding that our navigators have to be trained, and I'm talking about lay navigators have to be trained in order to help patients address the financial burden that they're facing. Scott Ramsey and his team from the University of Washington have published, I believe it was in 2016, a paper that confirmed that patients who have financial bankruptcy due to cancer, to medical hardship, I should say, have worse outcomes, and which result in an earlier death in patients that don't. So I think I just want to really put in my shout out for us to address this. It's very critical.
I absolutely agree with you. I think the notion of addressing financial needs is critical. I think the differentiation we're making is this term financial navigator, whose sole purpose is to help people enroll in insurance and not have any training around the cancer care continuum, is probably outside the scope of what we call a patient navigator.
Okay. Specific, okay. Sarah?
So I'm wondering, I'm curious if the training and certification group or any of the others have had discussions about, given what Dr. Winder said about, we're really going to focus navigation on those patients who are underserved. What does a complete navigation program look like? So if do you have to have a clinical navigator and a lay navigator to really call your navigation program complete? Do you have to have a financial navigator on top of that? So I think this group could do some thinking around that, because I think it ties back into what are we really asking policymakers for? Are we asking for just a fee-for-service navigation reimbursement, or are we asking for, what does a complete navigation program look like and what sustainability is for that program?
I think completeness is going to vary by your setting. Out in Indian country, we're never going to be able to have a navigator who is solely a financial navigator or who solely works with medication. Our navigators carry typically 5 different job descriptions on top of what they do for patient navigation. And that's true in most rural settings. So I think complete is going to vary by the funding stream, how well it's integrated within the healthcare system, and what other resources we have to support it. Personally, do I think we need community as well as clinical navigators? Absolutely. I know that most clinical settings, they would not get our patients into the door without our native navigators, our native sisters, stepping with them, crossing the threshold, and being with them so that there is a constant person rather than the 14 to 20 different healthcare providers they see during the course of their disease and their discomfort. It's also that the community navigator can deal with other issues that occur outside of the setting and much more holistically or spiritually, helping with ceremonies, helping with cultural issues, helping with family dynamics in dealing with the trauma of going through a cancer condition. And again, since so many of our patients are rural and in underserved areas, driving 200 miles one way, ending up with your adult child losing their job because they're constantly driving you back and forth into Albuquerque or into Rapid City or wherever it is. So I think completeness is going to be one of the areas that is tailored. And that's one of the things I think our committee has to also address but at a minimum, we want some things. And I think, yes.
I'm Electra Paskett from Ohio State University, and I just want to add on to what Linda said and maybe dispel some thoughts about what people might think navigation has to be. So we have a large navigation program for clinical care that we have termed Continuum of Care Navigation. And it combines community health workers who are out in the community. And I need to tell you, our communities are in Columbus, where we have Hispanic, African American, Somali, Nepalese, Bhutanese populations, as well as in Appalachia and in rural areas. So we have many different populations, many different settings. We use many types of navigation. We use telephonic navigation, and we use in-person navigation. But our community health workers go out in the community and they educate, and they're exactly what Linda said. They speak the language, they look like the specific populations, they have walked in their shoes, and they know how to speak to these people and what their needs are. They educate them about the needs, say, for care or a screening test or whatever. And then they bring them to the navigator. And our navigators, we don't have financial navigators. Our navigators do everything, and we train them. They figure out the insurance, and they qualify for insurance and decide if it's a mammogram the woman needs, where she's going to get the mammogram. Is it going to be on one of our mobiles, or is it a local place? And when we look at ways to pay for navigation, I'm going to get into care in just half a second. We look at, does the person have insurance? Do we qualify them for insurance? Is our Komen grant going to pay for it, or do we pay for it? And so we have a lot of opportunities, but our navigators do that. We don't have separate financial navigators. We can't afford to do that, and we don't want to divide up care. It's one person that deals with it. In our clinical settings, we have in-person navigation for the underserved populations. We just don't have enough navigators to deal with everybody. We focus on minorities, the underserved, and anybody on Medicaid. And my navigators are extremely, extremely busy. But they do the same thing. They can address financial issues. They can also address the community needs. My heat's getting turned off. I'm getting evicted. They are dealing with all of those problems. And what they have to support them is the hospital financial group, counselors. So it's really making those linkages internally in the hospital as well as externally. So I don't want us to fragment navigation. I don't want us to go to special areas when we can't afford this. We need a navigator that can talk to people, can get them in the door, can give them that support that they need, and then work with our internal and community-based resources. And it works that way. We don't have to fragment, as have been examples.
Thank you, Electra. Yeah, so we'll have the committee go ahead and respond to that, and then we'll go to Nina for questions. So response to
Great.
Electra.
I actually wanted to say, because I had a financial coordinator, if you talk about one position that will pay for itself in a nanosecond, it is that person, where we actually had inpatient screening through our PATHS department to identify our self-pay patients immediately versus our outpatient setting. We also did the same thing. She immediately would get those eligible patients onto Medicaid or Medicare where it was appropriate. Also get them into pharmaceutical, indigent programs, same thing for equipment, any other services that were needed. So my Alice, who's still there, who was just a tiger about it, she was all over these patients, and it actually kept them compliant with their treatment. So there are ways to actually pay for itself, but you also have to choose appropriate metrics to measure it. And, along with what we're saying, it's metrics is really what we really need to do to support all of this. But to think outside the box with that, when you are looking for other opportunities to finance that position, you need to look at metrics and the outcomes to support that. And I felt like I had to make a deal with the devil with my finance department to say, if you give me one person, I will prove to you that we can make a difference with our cancer program. And we did almost immediately. So there are opportunities. You just have to look for them and create some nice metrics.
Before we get to Nina, I just wanted to thank Electra for bringing up community health workers, because I was about to say that when Linda was talking. I think that we have to keep remembering that there is a whole cadre of community health workforce professionals who are, or I don't know the word, but healthcare providers and community providers who are doing a lot of the similar work in other areas too, primarily in other chronic diseases besides cancer, because in cancer, because Harold Freeman christened it, we really use navigation as the term, but a lot of, there's so much work going out there that is being done in the community, with community health workers, by community health workers. And I think we really need to partner with them, because a lot of the prevention work, let's face it, when you prevent cancer, you're preventing heart disease and stroke and all those types of things. So I think we really need to always have them in the back of our minds as well.
And I do want to just quickly say, I think a lot of organizations are thinking about the role and function of navigator and then the rest of the health team, whether it's enrollment, financial folks. I think this is going to be something for us to tackle, financial toxicity. Jean, to your point, I think this is something as a roundtable we are going to have to start making probably more definitive description around metrics, around role, and then thinking a little bit about how to support this work in the next year, and I think that's coming up loud and clear. So good things to tackle, good thoughts for consideration, and I can say that I think all groups will be considering this a little more deliberately. Nina, you finally get to ask a question.
Yeah, I don't have a question
Or
as
thought.
much as a comment. Nina Miller from the Commission on Cancer in Chicago. Just wanting to sort of say, I think that overall the task groups need to maybe keep in mind, and I think that I'm hearing it this morning, that we need to be thinking about navigation as a verb, not a noun. And I think that's really critical, and I've heard that from some of the great minds in this room, one of them who's I'm sitting right beside, Dr. Partridge, thank you. And I think that we have to talk about what does a navigated patient look like from A to B, not who's going to do that navigation. I think that's just really critical. So.
Great. Okay.
Thank you so much. I'm fascinated by this discussion. I'm Elba Saavedra from University of New Mexico, Comadre a Comadre program, and also Patient Navigation Network. The idea, and I appreciate the comments on community and clinic, what we practice in New Mexico. Sandra Arellano is from the New Mexico Patient Navigation Network with myself, and at Loveless, a patient navigator and program manager. And our program was co-founded with breast cancer survivors in the community. So our patient navigation, again, and I appreciate the comment of what in Hispanic Latina women that we work with, the navigated women are navigated by breast cancer survivors who are patient navigators and trained. And one of the things they emphasize is the importance of the emotional support and being able to be with someone that is similar to them, that understands their cancer experience in that contextual environment of the culture as well as the environment that they're experiencing that cancer, financial, immigrant status, the issue of distrust. So we work sort of a dovetail, and I think this discussion of community-based navigation with clinical, meaning that we dovetail with Sandra's referring women to Comadre program that are Hispanic Latina women. It dovetails the work so that we're not in competition and not the clinic navigator or the navigation that occurs at the facility level is not in competition with the community base, but actually in concert and working together. So this is just really wonderful that we still need to expand what navigation looks like, that it includes not only different types of navigators, but also addressing different types of needs, and as Dr. Freeman and others have mentioned, along that continuum of care, at different points in that continuum of care. So thank you so much.
Great. Any comments from the committee? Oh, sorry, Dr. Freeman? Okay.
Well, I think this is a very important discussion and given some thought to it. So if there is a healthcare continuum, and there is, and you could define it however you wish, but I think of it as everybody lives somewhere in a neighborhood. That's where people live. And that's where we have to begin to think about what to do for people. And if we're talking about navigation, it started with the point that people meet barriers when they attempt to get through the healthcare continuum from where they live to when they die. And if that's the challenge, if we look at the journey of the patient that we're trying to help must take in a timely way with good quality, that should be the first question, not the first question being who are we and what is our job. I'm a surgeon, but I surely couldn't do this as a surgeon. I started out like that. So I think it's important to me that we have people who have different skills and we can name them, lay, license, whatever. But the first thought should be, what is the challenge that the patient we're trying to help is facing to get through this complex system? And if we ask that question first, then we can, and that may vary in different parts of the geography of the country, as you've said. So what we do and who we assign may differ in different parts of the country under different circumstances. But the main thought that I have is to concentrate on the needs of the patient that we're trying to help to get across the continuum to a point of resolution. And secondary to that, assign the person to help them, whoever it is. It might be a different kind of person under different circumstances.
Great. Crystal? Oh, I'm sorry, Steve.
It's okay? Okay. Yeah, I think this is actually a terrific discussion. One of the biggest challenges I think that faces navigation is scalability. And I think if you look across navigation programs across many systems, you find navigation programs that are specific to breast or specific to colorectal. Most of them are funded by outside grants. But as a cancer center director and a person that gets an email a week from one of my 369 faculty members asking me for a navigator, okay? Literally, if I just had a navigator, all the problems in our disease group would be. So if I responded to each one of those emails positively, the Duke Cancer Institute would have more navigators than nurses or even physicians. And I don't mean to try to make that comical. It's a serious issue. So how do you scale a navigation program to address, let's say, a cancer center like mine that sees 175,000 patient visits a year at three different hospitals in 14 different locations across the state? So I think the comments that were made just a few moments ago are really important. We can't hire enough navigators to do this job. So we have to figure out, how do you screen patients for the highest needs? The risk stratification, so to speak. What we've tried to do at Duke is create a navigation network, or a matrix, I should say, that starts with using distress screening tool, that has digitalized it, measures distress screening in every patient every time they walk in the door, not just one time, so we have a longitudinal view of what their needs and barriers are, and then uses that information to refer to a network of navigators that span from community-facing navigators to nurse navigators to social workers who are handling crisis situations, who are cross-trained as navigators, to family counselors who can provide psychosocial support, to end-of-life counselors as well. And I can tell you from the perspective of a person that has to figure out how to pay for all this, you can't just hire an army of navigators. You've got to find a way to stitch a longitudinal program together that touches each step, as Harold said, of the continuum, but may be different job descriptions within the same matrix. So, sorry, long-winded way to say that scalability, I think, is one of the largest challenges that we face right now, and how to pay for it, and how to get health systems to think about navigation longitudinally so that they're willing to invest. I've been able to convince my system that it's worthwhile using some of the financial models that we have developed over time, but that's not the case elsewhere. So I think if we address scalability, you'll find more and more health systems willing to adopt navigation as an integrated process, rather than just have, the breast program's got a navigator and this program's got a navigator, and half the time they don't even talk to each other as well.
Yeah. We're going to go ahead and...
Can I just share a project that's going on? Because it's just being launched right now. It's a national study through AONM Plus, and we actually are partnering with Astellas to actually look at navigation acuity, because you really nailed it in regards to, we have to look at the distresses of our patients and the barriers, because that will measure the level of navigation we must provide. Everybody needs navigation, we know that, but everybody needs different levels of navigation, which is really important, because those patients that are going to need a higher level because their acuity is much higher, we got to keep a little bit closer tabs on them to keep them out of the hospital, keep them out of the emergency room, which are very good metrics. So again, I again turn to you and say, have some really good reports and metrics, because that is also going to result in potentially, if you do need additional FTEs, but also looking at the acuity. There's some sites they're actually assessing their patients before they've even met them walking through the door of their cancer program to even see if they're even going to make it to that first visit. Finding out what those barriers right up front is so absolutely essential. So we're going to be building that into what we're working with the National Navigation Evidence Metrics, that acuity tool that fits hand in hand. Because again, everywhere I go, everybody we talk to, what are the metrics and what is an acuity? Evidence-based navigation acuity are the next steps in regards to that. I know you.
Well, and I think, Steve, it would be really useful for us to share. I think one of the things that would be really helpful is a plug-and-play sort of economic model that then when, you know, the disease team presents to you, right, they're able to use their own data and, you know, say, here's the return on investment. So I think that's another thing that would be really important to come out of this group. That, you know, we could build it for screening, for diagnostic, the financial, you know, for active treatment. I know, Ed, you guys saved a ton of money at the end of life. You know, how do you build that so that people can use it and make their case?
Yeah, and I just want to say that I think there's some really good discussion about the tangibles, right? How all of this is really, and that's going to be the real next iteration of where we go. We heard a lot of that, so I think these are really good. But we're also going to need the experience of what are people in the field to help really build this, to make sure that it's representative as well. I think Crystal, and this is, Monica, is this the last time, the one for? Okay, then we'll have to wrap it up, okay.
So I'm Crystal Duggar. I am the AVP of Clinical Operations for Sarah Cannon, which is the cancer service line for HCA. And we do diagnose about 120,000 cancer patients a year and have the largest cancer navigation program in the United States. So we know it's scalable. We've done it across 180 hospitals using AI technology, things such as that, to prioritize our patients and send them to our navigators and continue to have an ROI and that type of thing, and a scorecard for retention, you know, timeliness of care. All the things that our administrators think are really important, productivity, things such as that. But I guess my big, in my learnings from that, I found that I love our task force. I actually am on the metrics task force, and yesterday I really challenged our group, and I challenge all of us, and that's really what I wanted to say today. You know, your administrators, I'm an old oncology nurse, navigator actually, that then went to the dark side, and then really went to the dark side and went to a for-profit, right? So I know what they're looking for, and honestly, they have so many things that they're hit at. You know, all these other service lines that are also very, very important. All of our patients are really important. I know that we really feel cancer is the most important, and I always feel like that when I walk into the Shark Tank, which is what I call it, with our administrators. But they cannot digest a book of information. So I really challenge our group. I think about, you know, even a surgeon clinic. Whenever we say these are the things that need to happen, we don't say this is how many employees they need to have in a surgery clinic. This is what all of these different, all the credentials of all the staff need to be. We don't say that. We just say here's the outcomes you have to have. Here's the certification for that physician. We say different things. We keep it high level, and I think one day we'll be able to go deeper. But I really challenge this group. Don't give so much information, or we don't have to build the whole thing today. If we had 3 good metrics for our top 3 stakeholders, if we have a very clear, I love academic too, but I love that it's very clear. That's why companies like myself, our companies love SG2, Oncology Roundtable. They have very clear things that an administrator that very likely has no clinical background at all can accept, take in, and really understand. And then even with our training and education, I think if we keep it high level, and these are the components that a good training and education, not necessarily this is who you need to go to or what, but if you're building this, these are the components they need to have. I just think that we would be able to be more impactful to organizations, community hospitals like myself, our hospitals, to be able to digest that information, and then we'd have the opportunity to go deeper, like the COC has, like NAPBC, like a lot of they didn't start with all those metrics, or all those standards. They start high level, or really said these are the critical things. And I wonder if really our task force, if they did that, I think a lot of our hospitals will be able to consume that information and be more impactful, because people can remember those things. They do this, this, and this.
And I think that's, yesterday it came up a good bit around knowing your audience, knowing the context, and then what are the really manageable questions and thoughts that really should come up for each targeted audience. So, Krista, I think your comment is really where a lot of this work is moving and translating into real products. So, Ed, are you, only people with Southern accents get to ask the last question. Okay, so go ahead, Ed.
Yeah, thank you. As far as risk prediction is concerned, I've learned a lot in the last year about how we might do that. When we were predicting risk in our Patient Care Connect CMS demonstration project with navigation, they didn't give us enough resources to navigate the 30,000 cancer patients that were in our network. So we did a really crude risk prediction. So if you had brain cancer or lung cancer or head and neck cancer or ovarian cancer or liquid cancer, you got navigation. If you were stage 4, you got navigation. If you had 2+ comorbidities, you got navigation. So all of us can identify those kind of patients at high risk. And that turned out to work pretty well, because they were more expensive than the other cancers in the non-metastatic cases. Rich talked a few minutes ago about using technology for oncologists to know how to treat somebody with all the markers and new biologics and everything that's going on. You can't keep enough of it in your head. There are predictive analytic forces out there, companies and so forth, that use neural networks. And you would be amazed at the amount of information that's publicly available on each and every one of us. That a company can buy the information, or the information's free. So you can take the medical record, their census report, where they live, their income, their credit score, their driving record, and you can predict with some reliability whether they are high risk or not for a readmission, for an unnecessary ER visit, depending on their disease. And not only can you predict risk, but you can predict impactability. That is, the likelihood that this particular patient would be compliant with the recommendations from the navigator. Can the navigator really make a difference? You know, a 72-year-old farmer who's been riding a tractor smoking a pack of cigarettes a day, you're probably not going to be able to get him to stop smoking after his lung cancer diagnosis. You might, but he's not very impactable, and you can predict that. We could predict that easily ourselves, but these neural networks can go even further. So the possibility exists that we can take that kind of technology, start applying it to how we dose navigation. Navigation can be dosed. Intense navigation, not so intense navigation. So you can use your resources wisely.
That's fantastic. I think that's a really provocative thought to end. Does anybody have any questions, thoughts from the committee? So we're going to go to a break, but when we come back, based on all that data that Ed talked about, we are going to look at who would be hardest and easiest to navigate into this room. So just kidding. So thank you guys so much. I want to give a huge round of applause for our committee.